All right, and we are live.
All right. Welcome everyone who has joined us already. I'm going to give it another minute or two to uh, let people trickle on in. We'll get started very soon. Give it another 30 seconds or so. It's still, that number keeps trickling up a little bit. A moment. Thank you for your patience, everybody. All right. I think that's pretty good. We'll go ahead and get started. So good afternoon or good morning, depending on where you're uh, viewing us from. Welcome to our discussion on public safety responses to people in crisis, best practices in promoting scene safety. Um, just so you all know, we are recording today's session. I think we already heard the lovely recording in progress voice pop up. So we'll go ahead and get started. I'll introduce myself first. My name is Joseph Arnett. I am a policy analyst here on the law enforcement team of the Behavioral Health Division at the Council of State Governments Justice Center. And I'm very excited to be part of this session today in collaboration with 21st Century Policing Solutions, aka 21CP. I'd first like to provide a bit of a rundown of how the session will go today. Next slide, please. We'll begin with just a overview of who we are at the Council of State Governments Justice Center, what we do, in case you're unfamiliar with us, followed by an introduction of today's presenters, and finally, I'll let them take it away and educate us all on the best practices to promote scene safety. So next slide. So who are we? The Council of State Governments is a national nonprofit, nonpartisan organization that combines the power of a membership association serving state officials in all three branches of government with policy and research expertise to develop strategies and increase public safety and strengthen communities. Next slide, please. And then next slide. So what do we do? We work with, we work to bring people together. We drive the criminal justice field forward with original research, build momentum for policy change, and provide expert assistance. Next slide. Our goals include breaking the cycle of incarceration, advancing health, opportunity, and equity, and using data to improve safety and justice. Next slide. The Council of State Governments Justice Center is committed to advancing racial equity internally and through our work with states, local communities, and tribal nations. We do this via providing high quality research, providing guidance and technical assistance to stakeholders to navigate the critical and at times uncomfortable issues the data reveals to improve outcomes across all touch points in the justice, behavioral health, crisis response, and reentry systems. So next slide, please. So now we'll get on to the good stuff without further ado. Our discussion on best practices to promote scene safety. Next slide. But one more thing before I officially turn it over to our presenters. We are actually going to be doing an Ask the Expert hour in 2 weeks with our presenters. I will momentarily, as soon as I turn it over to our presenters, I will put that registration link in the chat, and you'll also all be receiving it via email as well. So we hope to see you then. I'm sure we'll get to some questions in today's chat, but don't hesitate to use our Q&A function, which you should probably see at the bottom of your screen, to ask any and all questions that interest you. Anything that we don't get to today, we'll save and we'll definitely address in our next session. So we hope to see you there as well. And next slide. I would love to introduce our magnificent trio of presenters today, but I think they and all of you would best be served by me getting out of the way and turning it over to them to introduce themselves. So I'm going to give it to them. So Mr. Smoot, do you want to start us off?
It would be my pleasure, and thank you. Let me start by thanking CSG and the CSG Justice Center for hosting this webinar. It's a privilege to be part of it. This is an issue that has been really important in the law enforcement community and in developing policy and response policy for police officers across the country for the last several years. When we started planning for this webinar several months ago, I would have had no idea just how front burner this issue would be at this particular time, and how poignant it is for us to be talking about the best practices when it comes to responding to people who are in crisis or suffering with mental illness than at this particular time in recent history. So thank you, and thank you to my co-presenters, Martin Bartness and Randy DuPont, who truly are incredibly knowledgeable and considered to be, again, first-class experts in this area. Thank you.
Thank you, Sean. My name is Martin Bartness. I am currently holding the position of Senior Principal at the Police Executive Research Forum in the Management and Technical Assistance Center. We're based in Washington, D.C. I've been here for a little over 2 years. Prior to joining PERF, I served with the Baltimore Police Department for 25 years. I retired there as the Deputy Chief of Patrol and served in a variety of command positions there, from Chief of Staff to Commander of Education and Training, one of the patrol districts, Special Investigations, in performance standards. One of the projects of which I'm most proud and really enjoyed the work involved the creation of the department's crisis response program. The majority of that work was done under a consent decree with the Department of Justice and Civil Rights Division. And I had the good fortune of learning and working with both Randy DuPont and Sean Smoot in that particular area. Randy?
Thanks, Martin. Appreciate it. I really am excited about this topic. I'm really glad to see that we're able to bring it into some focus, because I never thought in my lifetime I would see the kind of ability for both police departments and community resources to come together in interventions and to be able to work and share that responsibility. I think we're really at an exciting time, and I do appreciate the fact that the Council on State Governments and CP21 is involved in bringing this to a wider audience. So thank you for that. I'm a professor at the University of Memphis. I've been best known for the work I've done with the Crisis Intervention Team program over the years. And again, as Martin mentioned, I have been involved with a number of consent decrees as a technical expert. My apologies for my mic at the end there. Thanks.
All right. Slide, please.
So we have a few objectives that we hope to obtain here in this webinar. And I guess we should also say thank you to everybody who's watching, and for those of you who are able to participate in the Q&A session later or via the chat today. we do appreciate you and appreciate your interest in this topic. Part of the objectives CSG has for this particular webinar is helping agencies maybe learn about new proactive steps that can be taken to ensure safety for all and to build trust with people in crisis. Also, to help officers understand how safety and support can enhance their collaboration and, frankly, help people who suffer from mental illness in accepting help from law enforcement officers or members of the community, perhaps, and or maybe some type of a co-responder, a mental health professional that might get involved based on law enforcement call. And then finally, we hope to give you some real life examples and protocols that you can implement based on the types of resources that your department has or your community has. Next. So since about 2013, responses to people in crisis by police, first responders, and communities have evolved significantly. Prior to 2013 and prior to President Obama's task force on 21st century policing, which really highlighted a number of areas of concern and took a lot of testimony with regard to how both law enforcement agencies, EMS, and mental health providers and community organizations can work together to essentially co-produce a safe response for people who are suffering. And that, rose out of a good deal of advocacy and community groups who, came before the task force, submitted written testimony, and provided real life live testimony about ways that mental health and substance abuse issues could be improved. And it's particularly the law enforcement community's response to those types of issues. Since that time, the evolution has really moved away from singularly placing a response on law enforcement agencies and their employees, police officers. And there's been a renewed way of thinking about it as a way to work with community groups and community-based resources. And now we have seen, and you'll hear some examples in a few minutes, about ways that community-based groups can work alongside law enforcement, sometimes without law enforcement's involvement, and also alongside and bring alongside resources from medical services, et cetera. There are a number of cooperative models that we're going to talk about. And one of the things that I'm really excited about in this area is this real opportunity for law enforcement to partner with agencies and organizations and professions that traditionally they have not partnered with. And that includes people in the medical world, the mental health provision world, and there are some really good grassroots community folks involved that officers can partner with as well. Next slide, please.
So if we can just take one step back just for a moment, I want to make just a couple of points there real quickly, Sean, if you don't mind.
Sure. Yeah, absolutely.
Thank you. Sam, if you can go back. Thank you. I appreciate it. I just want to put a fine point on an issue or two, and that really is the recognition across systems and from the community, and a real awakening and understanding that police aren't always, best equipped and the most appropriate entity to respond to people in crisis. And we learned that too often the hard way. But proud to see and say over the past decade, because of that awakening, a lot more resources are being poured into community-based programs, and causing police agencies, to ask themselves, how can we do this differently? Where can we lean on other resources? One, because it helps law enforcement reduce the burden, and there is a tremendous law enforcement burden with the staffing and recruitment crisis that is currently occurring, and what should be their primary responsibility of public safety. So we're encouraging police departments to constantly ask themselves the question, what are we doing to promote the least police involved response, and how are we challenging our partners in the jurisdictions where we work to step up? How is the health department? How is the behavioral health authority? How is the prosecutor's office, the public defender's office, hospitals, emergency rooms, the courts? How is everybody from a very holistic perspective doing their part to show up? How are they in their own way doing their part to resource response to people in crisis in a different way? So that's all I wanted to say, Sean. Thank you.
That's great. That's great, Martin, and thank you for doing that. And I would be remiss if I didn't give Dr. DuPont an opportunity if he has something he would like to add.
Yeah, Sean, I appreciate it. Yeah, indeed, I think Martin's making a very strong point here. That is that one of the things that I am so excited about is the opportunity for there to be models that work together, not just in terms of training, which is important, but also on the scene. And that's what's really changing. And I think the resources are changing in that regard. So I do think Martin's making a very important point here, and that one that we really need to spend more time on, not just obviously in this presentation, but over time as these models evolve, because they are quite different. And I think there's a lot of working out that needs to happen. So appreciate your comments, Sean.
Absolutely. I think we're ready for the next slide now.
Thank you. I'd like to frame this particular discussion in the context of resources and capacity. You'll see several response options on the slide here. And that is very, very resource driven. And not every jurisdiction is going to have the luxury, if you will, of having a robust 911 diversion program and mobile crisis response team staffed by paramedics or EMTs, nurses, clinicians who can respond 24/7 or 12 to 16 hours a day, 7 days a week. We're aware of that, but I think what is really absolutely essential, and no jurisdiction should get a pass on this, and that is, even where a police response is the only option, that they should be going it alone. Nobody should be going it alone. And a police-only response can still be fully informed by the behavioral health community. And by that, I mean, ensure that officers have high quality, community-driven and developed and participatory CIT training. And that means that policies, training, the development of training, the delivery of training, the evaluation of outputs and outcomes are beyond the police department. Everybody, all the stakeholders have a role, and that they're very actively involved in doing whatever that jurisdiction has the capacity to do. There are a good number of very high quality CIT training programs throughout the country. There's CIT International, there's the BJA's toolkit, which will refer to later in this presentation as well. National Alliance on Mental Illness. There are entities throughout the community beyond what you might typically think of agencies that are willing to step forward with their professionals to lend their expertise to be a part of this. So I want to encourage everyone to view these programs and protocols through that lens. Randy, would you like to add anything there?
Yeah, there's a couple of things indeed. I think you're making a real good point about the cooperative level of training and the integration between models like CIT and other models that have come along and that really add additional value. I think if you look at the bottom line there, 911 dispatch is not a one-way street. I think that's very important. What I'd like to see happen more is 911 and 988 to be interfaced in a meaningful way. It's starting to happen in a few cities. I know it's happening in Baltimore, for example, but I think many cities are not really caught on to the fact that if they can have a technology that allows them to go back and forth between 911 and 988, it'll really be for the betterment of a community response. The second thing I want to add is that I know sometimes smaller jurisdictions begin to get overwhelmed by the myriad of options, but I want to point out something that in many ways we're coming back to something. If you look at the main program of crisis response, they've always crossed over between not just agencies, but also with EMS and mental health in making joint responses and cooperatively working that out. And so I think we have something to learn that this indeed is something that could be done at rural areas that don't always have that ability. Another example I think would be Johnstown, up in the Johnstown, Pennsylvania area, where they crossed over agencies and what would be county lines to be able to develop cooperative programs. So I think this is a pretty exciting time. And as you point out, I really think it's very critical to kind of develop a new approach and a new concept, starting with the initial dispatch and then moving on to the kind of intervention, training and intervention that you're talking about. So, Sean, if you want, ready for something, or do you want to go to the next slide?
No, I just would like, I want to point out there are a couple of things, and I agree 100% with both of you. No surprise there. But one way I'm seeing departments actually find partners is through their own mental health and wellness programming. And that a lot of times is a good way. If you have a robust mental health and wellness program for your officers, that could provide you with kind of a seed of folks that are involved with that program that would be willing, and that that police officers would feel comfortable actually integrating into their response when they go, because they'd be comfortable knowing these people and having had the opportunity to work with them. The other thing I wanted to mention, and I do a lot of work on college and university campuses through 21CP, and I've seen some pretty impressive programming on college and university campuses, which integrates the university's mental health providers, EMS, and volunteers who are actually students that are interested in studying psychology or sociology, and they develop a program to coordinate with campus security or the campus police department during off hours. It's not unusual if you're a student in crisis at one of our major universities and you call for help, for you to also have the approach be made not by somebody in a uniform, but actually by another student who's there to help. So I think those types of programs are really useful as well. And we're seeing more and more community-led programming along those lines too. The last thing I want to say is there's grant money out there that folks should be aware of, both through the Department of Justice, but also through a number of not-for-profit grant-making organizations. Depending on what region of the country you're in, if your police department is interested in starting a program or really enhancing your program, there are a number of places that you can go to help you get the funding. The money shouldn't be the total obstacle here. Thanks, Randy.
I'm not sure who calls it, but let's take a look at the next slide. Martin, I think you're taking this away with Joseph, I remember right.
Yes, sir, that's correct. We're going to show a video here. It's a clip from body worn camera footage. It's just over a minute long. It is an incident from 2019 involving the Baltimore Police Department's crisis response team. The crisis response team there is a co-responder unit with a police officer and a clinician who are responding in real time to some of the most acute crisis calls for service. This is, not a particularly flashy incident. You're not going to see a use of force or anything like that. And that's with intention, because that's how most of these calls are. But what I do want you to pay attention to is the familiarity of everyone involved, the working relationship between the clinician and the police officer, the relationship with the fire department, even the relationship between that co-responder team and the person in crisis that they're talking off of a bridge. You can go ahead and play the video, Sam.
We're on Howard Street again with the guy on top of a bridge. That's all right. We can still talk to him from there.
Am I able to go up there yet?
Sure.
Yeah, I know him.
Sure. Yeah, you're good.
Is that? Okay. Hey. Hey. Do you remember me? Hi. What's going on? If you come down, then I can talk with you a little bit more. He said he's willing to go with us to Hopkins, try and get some more help.
Okay, cool.
Huh?
We can do that.
Yeah, we'll take you.
Martin, I want to add that for those that don't know, the person that was intervening up at top of the ladder is a social worker who is part of the mobile crisis agency, who then interfaces as part of the co-responder team with the police department in Baltimore for their crisis intervention team. They, of course, not only have that, but they have a CIT program that starts out with a broader range and a broader reach, and then they interface with the community resources that include the mobile team itself. So let me pass it back to you, Martin.
Thanks, Randy, and maybe we'll see some questions that surface from our audience that we can answer after our presentation. But I think this really shows how the system can work. This is an individual who was on the phone. It's a mental health clinic that is speaking with him. They're unable to obviously resolve the situation over the phone, so it gets referred to our crisis response team. They get there. They have a pre-existing relationship. They've talked him down from this very same bridge before, and bless her, the clinician's willing to walk up that very tall ladder up to the bridge. And when they get him down, he's very agreeable to going to the hospital with them, where he is currently under the care of a physician. So it all works very smoothly. You can see he's walking into the hospital. He's not restrained in any way, and he's going to get the care he needs.
Just a real quick interjection. Please, just a reminder to everyone, if you want to use the Q&A function at the bottom of your screen to ask any questions, please do so. I'll keep an eye on it and see if we can address any questions as they come in.
I do think we have one that's kind of interesting already on that part. Would you want us to tackle that now, Joseph, or wait till the end?
Whichever you feel is let's
what they bring up is an issue that can be challenging, which is the one of handcuffing and how that plays out. And departments do handle that differently depending on their policy. Martin, I know that was an issue in Baltimore, so I don't want to preempt you from commenting, but we did make that a significant part of the policy issue, and which officers have discretion in making that decision as to whether a person is handcuffed or not. Not all departments allow that discretion, but in some departments they do. And I think that that's an issue that each department needs to resolve with the community to figure out what will work best for them. So indeed, for some departments, they're going to do that. I think most departments give it to be discretion. That's the way it's moving in these directions. Discretion of the officer at that point. So I'm ready to move on when y'all are. Well, I see another one there, but I haven't looked at it.
There is a question in the Q&A about the difference between community-based violence intervention and prevention, and a co-responder model. And I think the two things sometimes do get conflated, but generally community-based violence intervention and prevention programs are specifically targeted at reducing specific issues, most commonly gun violence, and intercepting people who are likely to commit or to be victims of gun violence. And that's probably, I would say, 90% of what would be considered a community-based violence intervention and prevention program. The co-response model or co-responder model is one, and we'll get into a little bit more detail on this, but essentially the idea that when there is a call for someone who is in crisis, or is known to have mental health challenges, that the police would not be necessarily even the primary responder, but could be responded by a co-responder, could be a mental health professional that goes with the police officer, or could be a community counselor who goes in response to the call and has an officer standing by. So there's a lot of different variances. We'll get into more of those on the co-responder model, but that's generally the difference between those two things. I think, Martin, there's a Baltimore specific question in here, if you care to address it.
Yeah, I actually think, oh, I missed that one. Let's see here.
There's a third one down below. Yeah. Martin, I can help you a little bit with that, because what they're asking there is basically they're in their county, law enforcement has to make the transfer to hospitals. I'm assuming that's in the grounds of an involuntary or a commitment under state law. In some cities, it varies. And generally, some places will have a very active role for EMT. I know in Cleveland, the police department is involved, of course, but they have a very strong role for the EMS services to make those transfers, even when there's an involuntary commitment. It depends on the judgment of those involved. And I think in Baltimore, you get much more involvement with the fire department when it's voluntary. And in some cities, it involves mobile crisis. So I think each city is working it out. And I think that we're in a period of transition on that, where we need to reassess and try to figure out what makes the most sense. But again, it is there's no one answer as you move through the country, as people are trying to develop new models of how to intervene. We have a final question, which I haven't read yet. If somebody else has, please take it.
I think this one is more
comment more than a question.
Yeah, more of a comment than a question, but actually one that I kind of had in mind as well, is that it was one thing I really loved in the video that we played is the fact that the person was able to kind of start things off with a, "Hey, remember me?" And how kind of great that is, and how beneficial that is to kind of build that rapport and to be able to start off that interaction with, this, "Hey, remember me?" That's, very reassuring. You're always kind of more comfortable with somebody you're familiar with versus a stranger. So I had the same thought, Ms. Jones-Williams.
Indeed, it was pretty.
Next slide. Great. Thank you. So the key to effective co-response as it relates to roles, communication, and best practices between personnel, I believe is having a plan and gathering as much information as possible before even going to the call. And this will probably come up a little bit later in our presentation as well. Being from Perf, I'm an advocate of ICAT, integrating communication assessment and tactics, which uses the critical decision-making model, which is an iterative process of gathering information and making decisions and constantly assessing the scenario and reevaluating to ensure the desired outcomes are achieved. And all of those decisions are made around a set of core values, most critically the sanctity of human life, and centering that and ensuring that's what we're striving to uphold throughout the entire incident. As far as developing the plan, developing a plan and how we gather that information, the 911 information is key. The opportunity to often call back that 911 caller is typically there to gather additional information that the 911 operator and dispatcher don't have. I always believe when you get there on scene, you have the opportunity in many cases to make additional assessments about what is occurring and is there a safety threat or weapons present. Is in some cases we're getting a hotline referral. There may be some kind of additional information that you can get about the parties involved to help you determine the best way to approach this incident. Who's going to take the lead? Does it require the law enforcement officer or can the clinician take the lead? And usually that is the case. Sometimes circumstances are maybe too volatile for that to occur, and the clinician may need to take a backseat role until the situation is stabilized a little bit more, or at least able to establish communication with the person who is involved. Part of this too, in terms of an effective co-response, is co-training or cross-training among all the entities who are involved, so that they understand one another's role, a little bit about the training and education and expertise that they bring to the table, so that they get comfortable with each other and they know each other's capabilities. And then you're really forming a team that can be highly effective. Another, behind all of these scenes, it's being patient, going slow, taking your time, going in with the understanding that if you need to retreat, you need to perform a tactical retreat because that's in the best interest of everyone's safety. That's what is done. And then the scene is held and secured until additional resources can be brought to the scene and bring some additional options to the table to resolve the situation peacefully. Practicing throughout all training, active bystandership, making sure you're emphasizing a culture of, checking the ego at the door. All of those things are really important, and it can't just occur in behavioral health response training or CIT training. It's going to be threaded throughout all trainings, and that takes time. But a very deliberate, intentional process of doing that, of taking that approach, really has profound implications over the long term into a police department's culture and how they respond and interact to the public, particularly to people in crisis. Sean, is there anything you'd like to add?
You're spot on 100%. And let me just reiterate, I fully endorse ICAT training. It is, I think, one of the best developments in policing in the last 20 years, easily. So if as 21CP recommends it to many of our clients when they're looking for a way to train their officers, I just think I can't say enough good things about it. I mean, if your department is not getting ICAT training, you should get in touch with Martin get in touch with Perf and see that they do. I just want to say about these questions, these are really important. And the answers, what the answers are to these questions are really less important than having an answer. The last thing you want to be doing when you're co-responding to someone who's in crisis is trying to figure out who should take the lead, how we're going to communicate with each other, etc. I mean, I just want to emphasize, having an answer to the questions, it'll be different. There's no like one size fits all answer to who takes the lead or how they best can communicate with each other, etc. But you got to have a plan, and that plan involves who's going to take the role of initial engagement, and what kind of a signal they can give the other person if maybe they feel like they're losing their connection with the person, so that other co-responder can take the opportunity to kind of step in and continue. I mean, part of this process is really I think Randy, you would agree with me, is keeping the person engaged and communicate.
Well, I remember, Sean, one of the things I wanted to emphasize was that when we were talking about this particular slide and preparing for this, both you and Martin, as well as the work that I've done, we've done thousands of body-worn camera reviews. And what was agreed upon was that the one thing that immediately differentiates between what we think is going in the right direction and one that doesn't go in the right direction in terms of where it's heading, has got to do with the planning and the ability to kind of coordinate it. And that I know that in many of the trainings that I'm involved with and that others y'all are involved with, there's actually a part of that in which they do an initial get together, a rendezvous, to be able to take a few seconds and plan. So what y'all are pointing out is very critical. Who's got the lead? How did the communication occur? How much is that part of training and how much is that built into the scenarios of training? So a good point. But again, with that kind of experience that all of us have, what we really emphasized a lot was just on the front end, is there a coordination and planning that comes out right early in the body-worn camera footage? Thanks, Sean.
A couple of folks have asked me to repeat the name of that course. It's Integrating Communications Assessment and Tactics. ICAT is the abbreviation. You can go on Perf's website. There are tabs dedicated to it. We share it very willingly. We're not making money off of it. We actually we have a facility in Decatur, Illinois, a wonderful training facility that's been built courtesy of Howard Buffett. And if you're able to get your officers there to Decatur, Illinois, we provide the training free of charge. We're very passionate about it. We believe very firmly it saves lives. Independent randomized control study by Robin Engel at the time at the University of Cincinnati found that it reduces injuries to police officers, it reduces injuries to citizens, and it reduces use of force. So we're proud of it, but at the end of the day, what it's really doing is it's encouraging officers to take things slow. Sometimes, you hold and instead of push, you back out, you bring additional resources to bear, and you continue to communicate and de-escalate that incident and work your options.
Martin, there's another question. Oh, I'm sorry. Go ahead, Sean.
No, I was just going to say there's a couple other questions in here that I just real quick can answer. Number one, Morgan, yes, I would recommend ICAT for correctional environment as well. And so that's just a yes. It's good decision making, tactical training, and it's really a philosophy on how you respond to situations where that are dynamic, and that works regardless of whether you're inside a corrections facility or inside a grocery store. I think they're both applicable. The other question, Tiffany Huffman asked if officers are required to have additional training in dealing with folks who may be suffering from mental health issues, and the answer to that is in some places, yes. In the state of Illinois, they're required. There's a mandatory hourly requirement for CIT, crisis intervention training. I believe that's been adopted. That mandatory model has been adopted in a number of other states as well, certainly including California, and it's also part of I believe every department that's implemented a consent decree has implemented a robust CIT requirement as well. Martin and Randy, you might know better than I, like all of the other states, but
yeah, I think it is a standard part. Also, I think ICAT has been something that's been offered to most officers as part of the training as well. And the CIT training or a version of that's also available as they move up the ladder of experience. Let me also respond to Scott's comment, which is Scott Wilson is saying about body language. Scott, I think that's absolutely true. There's a lot of time spent in most good programs, most good training programs on body language. There's some research out on what people really pay attention to. Body language and speech tone, of course, being important. So yes, that's a critical element. And I would look for that in your department's training and see how much time's put in on that at all levels, not just at the highest levels, which might be CIT or a mobile or a co-responder team, but at the level of basic training for the officers. And Martin, you want to take the one on from Mark there? He's asking, is ICAT only for law enforcement or is it open to mental health providers?
So we do not currently offer an indicator to crisis mental health providers. I will say this, the department I've come from in Baltimore, we would, as the local agency, absolutely welcome with open arms our crisis mental health providers to take that course with our police officers. We would want them to do it. We would have our co-responding clinicians to have taken that course, just as we would want them to have taken the 40-hour CIT training course. That is the kind of cross-training that I think is so essential for those teams to be doing. One of those courses is great. Taking both of them is even better. CIT training is a 40-hour course. It's covering topics such as substance use disorders, PTSD, suicide, veterans, community-based resources. There are a lot of scenario-based training and de-escalation skills in those classes. There's a lot of talk about stigma, perceptions, and attitudes around behavioral health and disabilities and intellectual and developmental disabilities. This is complex stuff, and we need to be investing in our personnel as much as we possibly can. There are a number of different ways, which I hope that's one of your big takeaways here today. There are multiple ways of structuring these programs, and we're not here to suggest that there is one right way, but it is absolutely critical that those on the front line who are responding to these calls for service, whether in some cases it's a volunteer program where a quarter to a third of all patrol responding officers will be CIT trained, and when a behavioral health related call for service comes in, they're the ones that get dispatched. Other departments will train all of their officers in CIT, and then the calls are just dispatched on a geographic basis, et cetera. Randy with the Memphis model is a proponent of the volunteer approach, and that's certainly what is being implemented in Baltimore. So I see the value in that, but there's also there are additional challenges that come with it.
Mark, what I want to add though is what's happening in Baltimore, that I know you were actually one of the ones that was driving it, is that you have a start with a 24-hour intensive mental health course for all officers. They then move to an ICAT course for all officers. And then finally, those that are interested in CIT, which involves a fairly high percentage of the force, also take it, and they become the CIT officers that kind of take the leadership. So That training, I think, across the board has paid a big dividend for Baltimore. When we look at the body-worn camera footage, there's a report out that's publicly available that is very impressive about the results that we've seen. So I think that indeed that model has worked well. Martin, I'm going to ask you to handle the one on, is there a adaptation for corrections? Because I know there is for CIT, that there's a corrections for CIT and a specialized training. How about the more broad-based ICAD training? Is that also available for corrections?
Yeah, we have had extensive conversations regarding corrections, because there's some unique challenges with that population. This ICAD absolutely works. We teach it to a lot of sheriff's departments across the country. And so, yes, it is, it's very applicable. We have a team that is dedicated to doing this training. When they're not in Decatur, they're traveling to agencies across the country of all different types. So the short answer to that is yes.
Let me respond to Anita's question there. Anita, I think one of the most critical things that's not as strongly emphasized as it should be is basic and intense training for those that work in halfway houses and other such places. I think that they can really make a difference in the need to even call 911 or 988 in the first place. So absolutely, I think that that's important. I am familiar with an informal study that was done in the Cleveland area where they provided training and decreased the calls to the police by 50%. So I think that kind of training is absolutely critical and really almost should be a requirement for those in the work with halfway houses and other such places as well. You want to take the next one about applicability EMS and firefighters? That's from Leanne Fitzpatrick, Martin.
You know, because we are, you know, at PERF, we're a law enforcement organization, we have focused it on police officers. Are the principles and in particular the critical decision-making model applicable? Do I think the profession, the firefighting profession, EMS, could take what we have and customize it for their personnel, and would it be appropriate? I do think that. I wouldn't want to take it as it is in its current form without that customization, though, because so much of this too is, look, it's got to have an internal credibility to the men and women who are doing that work on the ground. And so they need to be a part of that development and the ownership of it so that they can, you know, preach the gospel, so to speak. You know, that they really have to believe it in and believe that it works specifically for the challenges that they confront in the field every day.
And I would emphasize that I think it's not just about the ICAT training. What we really need is co-development of policies, cooperation between EMS and police and the mobile crisis teams, community resources, and we need to have that co-training, whether it's at the ICAT level or whether it's a more general training that's customized and developed. I'd really strongly emphasize that it's happening in some departments. Again, in Martin's department in Baltimore, they recently had a co-training with fire department in a way that was been well received. So I really strongly emphasize it's not just about getting a formal training like ICAD when it comes to working with EMS and firefighters. And in more models, EMS is becoming a critical part of the intervention. So I do think we need to kind of look at kind of what's happening in general in co-training in those models as well. So don't give up if you don't have availability to a systematic program. I think it can be developed at the local level with the expertise and the partnerships we're talking about. Martin, I think we're ready for the next slide.
Yes, sir. So this question, and we have 3 slides on it, and that says something in itself. This is a primary concern of people who are considering transitioning to a co-responder model of some kind. You know, is it safe for everyone who is involved? Is it safe for clinicians to be going on these calls for service by themselves with the EMTs or nurses? Is it safe for police officers to be working with clinicians on acute calls for service? And I'm going to give you a few points of data where I think we can walk away with an emphatic yes as the response. The Cleveland Division of Police surveyed their officers. This is a 2024 survey, I believe. They found, or they reported that less than 5% of mental health calls for service involved a critical public safety issue. You know, cops can be a tough audience to survey. They're known for, you know, kind of telling it like it is. And so this particular survey result, I think really speaks to the characteristics of most behavioral health related calls. Typically, the threat of violence is not present. And we know that from other studies as well. Slide 17, CAHOOTS, one of the most well-known mobile crisis intervention programs in the country, been around.
I think we need to move on to the next slide, I believe.
Yeah, here we are. I'm at CAHOOTS.
Okay, now we're on the screen.
Okay.
Yeah,
Thank you.
great. Sorry, Martin.
No, thank you. One of the most well-known mobile crisis intervention programs in the country in Eugene, Oregon, been around for about 30 years. They respond 24/7 with a nurse or EMT and an experienced crisis worker. The results are very impressive. They're handling a huge volume of calls. Less than 1% of those calls did they need assistance from police, and no one has been seriously injured on those calls. The number of calls that they're handling on an annual basis since they've been in existence has increased, and to date, they're diverting about anywhere from 3 to 8% of calls for service from police. That has huge implications today for the profession's staffing and retention crisis. It's reducing that call burden for police officers. It's putting it in the hands of professionals who are well suited to de-escalate when necessary, and then link those individuals to community care and managed care services. The next slide, Sam, is another example. STAR program out of Denver, Colorado. Again, they are responding independently of police officers. They handled 5,700 calls in 2022. They never had to request police backup on call due to a safety issue. They do not operate 24/7. They are in operation about 16 hours a day. And they, of course, are being deployed during those 16 hours when calls for service are greatest from 6 a.m. To 10 p.m.
Martin, I want to emphasize too that all three models you just covered each have different ways or different structures, and yet they're all finding the same results with regards to the safety issues you bring up.
Next slide. You want to start off on this one, Randy, and I'll pick up?
Yeah, folks, we're looking at some of the models that we've already discussed. One thing I can't help but want to mention is that early on in the process of learning about models, I did get to have a presentation from the Eugene, Oregon staff before they were well known. And one of the things they emphasized was the fact that it was so cooperative and that they felt that the CIT officers was their best ally in providing their services. So again, what I'm impressed with is the way that these models that have really come on strong lately are integrated with earlier models that have well accepted and are often successful throughout the nation. We've already mentioned a little bit about Baltimore, Maryland, which is that basically they have a model that involves a starting place where they have a 911, 988 diversion program. They indeed can go back and forth between the two depending on which is the best suited to handle a situation or depending on new information that emerges. Then they have options that range all the way from a crisis intervention team program that's intense and involved to having another level of response with the co-responder model, which involves both police and mental health team working together. And then finally, they have a complete option of turning to a mobile crisis team, which is a community-based team that does not involve bringing the police as part of the active team and intervening. Very impressive sets of models there that are bringing some unique aspects to it. Eugene, my understanding, has a more basically consensus-based model of development out of 911, Whereas on the other hand, Baltimore's model is based more on a pro Q&A system of 911 categorization, which then leads to whether diversion occurs or not. Cleveland also has developed a co-responder model in which they really get many of their referrals from the CIT program, which is fairly extensive there. And it allows there to be a more intensive response and sometimes a follow-up that's, again, better connected with the mental health system in order to try to bring about a resolution and services needed for any crisis events. Portland has kind of an interesting model. It's very different in many ways. They call it Portland Street Response. It is different. It is more based in the EMS program. They do also have crisis intervention capacity within the police department, but the Portland Police Response provides a very different approach, but is really out of the fire department and has had some good success in recent years. Martin, would you want to comment? I'm sorry, Sean, go for it.
Yeah, no, if I just want to jump in real quick and just say, because I've actually been to all three of these agencies. And for those of you who are watching and thinking about ways that you can start a program or enhance a program, I would be very comfortable telling you that you can contact any one of these four agencies, and they would welcome you to come and do a site visit. They would take your call. They would answer your questions. They are extremely proud, as they should be, of their programming. And I would really encourage you to go. I mean, I visited Eugene, Oregon, I don't know, close to 10 years ago when Cahoots was maybe 2 years old. They were just incredibly generous with their time, explaining how they had set it up, talking about successes and then, some of the challenges that they had. And they are a welcoming agency, as is Baltimore, as is Cleveland, and as is Portland. They really are open to having folks come take a look at what they're doing, and talking you through it. And actually, I did a couple ride-alongs at each of these places. So I think if you're serious and you really think, wow, that program looks good, and it would be worth your investment to actually go do a site visit there and see what they're doing firsthand.
Thanks, Sean. I just want to take a moment to describe a little bit about what it was like in Baltimore. Baltimore's not unique. Before it began kind of this transformation that was born of the consent decree, which was, it began, the investigation by the Department of Justice began in 2016 in the wake of the death of Freddie Gray, and a findings report was issued, and we entered into an agreement with the federal government to remedy Fourth Amendment violations, et cetera. In the area of behavioral health, the findings very much focused on unreasonable force used against individuals with mental health disabilities or those in crisis, officers failing to de-escalate encounters with unarmed individuals with mental disabilities and those in crisis, arresting unnecessarily and often without probable cause people in crisis, taking people to emergency rooms on emergency petition orders when really the criteria for an emergency petition had been met. And so all this now was becoming a more and more robust system. I think every day is the byproduct of that investigation and learning from, kind of the errors of the ways of the community. And it, the focus initially was on the police department, but when you get into the work of it, and what you quickly realize is that this is a much broader system, and the police are the tip of the spear within that big system. And that system, had insufficient real-time crisis response from behavioral health professionals. It was an underutilized crisis response hotline. There are an insufficient number of psychiatric beds. There are a lack of sobering centers and community-based treatment, et cetera. So Baltimore has done, and many other cities who have taken this course, some by virtue of a court order, others because it's the right thing to do, in building policy, training, in a collaborative fashion with all of the stakeholders at the table, and then building systems of ongoing audit and inspection to make sure that policy is being followed and desired outputs and outcomes are being achieved. And that's the kind of work that is going on now. But I just wanted to provide that context to where we are today.
Martin, I notice we have a question as well from asking about the fact that some of these models, many of the models that we're covering are from urban areas. Have you seen any rural-based challenge activities? I would tell you that indeed we have probably emphasized the more well-known models, but on the other hand, there are models, as I mentioned, the state of Maine had a model that basically involved a cooperative level throughout a number of rural areas that I think was worth imitating and that one should contact their NAMI organization to learn more about. But I'd emphasize another one as well, that is the state of Mississippi, which indeed is not always known for having strong mental health funding, nonetheless has done an incredible job of developing and making use of that funding efficiently to create crisis intervention strategies that are really very much based across the whole state, including some of the more rural areas. So I think it can be done. Again, I'm sure Council on State Government could put you in touch with the people in the Department of Mental Health that helped develop that model in Mississippi. But again, I've been impressed with both Maine and Mississippi's work in the rural areas. So I think it's very much possible.
I want to point out too that in the chat, Joe Arnett, who's on the call here, has very graciously offered to help facilitate connections for folks who are on the webinar. And he's also very aptly, and I apologize for not mentioning it, but there are a number of law enforcement mental health learning sites around the country that CSG is involved in cooperation with the U.S. Department of Justice. So those are both really great, and those are in the chat. So Joe has included his email in the chat if you want to reach out to him to see if he can connect you with some of these folks.
Appreciate you you highlighting that. Yeah, feel free to reach out to me. My email will be on screen, I believe, at the end of the presentation, and it's also in the chat. And also, with one other thing, and I want to be mindful of time because I think we're coming up on 20 minutes or so left. But yes, we do a lot of, we think a lot about the fact that most law enforcement agencies are very small areas, rural. We actually have a colleague here, and I could see us maybe possibly going kind of deeper into this in our follow-up session. But I have a colleague who's from very, very rural Tennessee, and this is sort of his passion topic of the various unique circumstances and sort of things that affect very small rural departments. So that is definitely something we are mindful of, and yeah, I'd love to dive into this topic deeper. And Ms. Ribnick, if you want any other information on that topic, feel free to reach out to me. I'd love to provide it directly.
Joseph, I'm guessing I'm going to ask the question, or are we at a point where we need to finish out the slides, or do we want to stay?
Yeah,
where are we?
Let's
I'm going to turn
let's
that
move on
over to
just
you
to
and
make
Sean.
sure we get everything. But we'll get it if we get it.
Well, there was a
before,
comment
our time. We can always
that,
circle back to more questions.
There was a comment from Jennifer about work that's being done in Connecticut. Connecticut's known for the fact that they've done models that really cross around the entire state. They've done that not only with CIT, but I see her comment that Social Workers and Law Enforcement Project is also doing the same thing. So I want to keep encouraging that kind of involvement. And then Todd has a question here about co-responder teams. And you're talking about two different models indeed. One model is the one of can they respond to the adequate demand. I think that's the challenge for community-based mobile responder teams and co-responder teams. Can they handle the volume of calls? Are there enough? And I think that's the challenge that cities are facing. I know that if we've mentioned where Martin's from in Baltimore, they moved from 5 to 15 mobile crisis teams to be able to handle their challenges, but they do stay with a model that's more focused on crisis event. Others do, and I think you've maybe classified Cleveland that looks more like not only responding to some crisis events, but they do important follow-up to make sure the connections are there. So I do think that those are models that are in development, and I think in the end, we're going to have to look at what kind of resources are available that would allow for either the larger scale response you mentioned in the beginning, or the more intensive response with a follow-up. Indeed, that's the case. Martin, I haven't looked at the next one, but if you want to look at it, go ahead, please, and take a shot.
Yeah, so Sanders' question is, what examples of alternate civilian response have you studied since SAMHSA's national guidelines for behavioral health crisis response recommend that mobile crisis teams should incorporate peers, but avoid law enforcement accompaniment in most circumstances?
I can go ahead and answer again, as it turns out, because Martin, in your area, Baltimore, they have really made a commitment to including peers in their models. That's not the truth. That's not the case for throughout the country, but indeed they are working with that and have made major commitments to it. I think the question of avoiding law enforcement accompaniment is an interesting one. That is that, again, it gets into what Martin talked about. To what extent have you worked out protocols that would allow for that? And what is your protocol for how, if a situation develops where there is a need to involve the police? I think those are the critical elements that are involved. But I do think that mobile teams that stand on their own are a good model, that they complement co-responder teams and CIT programs nicely, because again, a number of those calls do not need a police response in the end. But again, I think we're in a transitional period where we're trying to figure out which ones fits better for what areas.
I agree with that 100%. And I think, it's important that we also don't lose sight of the fact that, unfortunately, in many places, law enforcement is still the only resource that's available. And so,
particularly in rural areas, I think you're right, Sean.
That needs to change, but it's a reality.
Yeah. Joseph, we're going to let you decide where we take it next.
Let's go on to the next slide, and we'll make sure to get all those in. Like I said, any questions that we aren't able to get to here, we will either definitely incorporate them in our Ask the Expert follow-up, or I will make sure we reach out to you directly on them.
Yeah, I mean, just to start, this is really where the rubber meets the road in terms of minimally, what types of things do officers need to be trained about when it comes to responding to someone in crisis. And like, obviously, at least in my mind, like, first and foremost, they need to be trained in how to recognize what they're dealing with. And fortunately, there's been some very good training, and certainly emphasis on training. And someone asked earlier about mandatory CIT training or mandatory training for dealing with folks who are suffering from mental illness. Being able to identify quickly if that's in fact what the situation is, and then being able to switch into mental health response mode is crucial. And I think that there's some really good trainings out there. Randy has been really at the forefront of training in that regard, but this idea of immediately being able to recognize it and move to de-escalate the situation. And this has to do with some of the excellent questions we got earlier about, like, or comments we got earlier about, the intonation of the officer's voice, the way that they stand, the mannerisms that they display. And in many cases, you'll see when an officer is engaging initially with someone in mental health, there could be a mimicking of, or mirroring of, kind of statures and response. And that, if you don't recognize that that's happening, that could be misinterpreted as aggression, and that might cause an officer to use some different options than de-escalation and bringing the temperature down. And so those are things that are out there. Also, knowing that there are other resources that they can call upon. And I'll kind of hand it off to you, Randy, for a moment, if you wouldn't mind, just because you have been at the forefront of training officers in this space.
Thank you, Sean. I appreciate it. I do think that when we look at that first slide, as you mentioned, what really makes it work, and I think Martin would support this as well, is when you've got a cooperative effort between police and their training expertise, but that you now bring in expertise from the local community, the professionals that understand mental health and can respond, but who also bring in people with lived experience. Officers in Baltimore rated some of those lectures, as you were, really, they were really more conversations that were really impressive. And again, so if you bring in all three elements, police training, the mental health professionals that volunteer their time from your own community, and peer-driven interventions such as those of lived experience, you really get quite a difference. If we look at multidisciplinary training curricula, folks, the first one that jumps out to me is what's done in Ohio. Ohio has a top-to-bottom training curriculum for all officers, for CIT, for other interventions as well, that was developed in the kind of way we're talking about. Those individual cities you see have done excellent jobs by bringing together their local resources and developing a curriculum that was unique to their area as well. And then finally, we've talked in the past about, in this presentation, about the importance of having cooperative training across areas that involve the similar training that's going to go with 911, that have peer involvement and peer counselors' involvement. Those things, again, are very, very critical. Joseph, I think you're the one that knows more about CRIT, so I'll pass it back to you for some mention about that as well.
Yeah, I can definitely speak to that. So the Bureau of Justice Assistance supported the Academic Training Initiative to Informed Police Responses, very succinct name there, in developing this resource to support the implementation of many different crisis response models, not just limited to crisis intervention teams. It is free and it's broken up into modules, so agencies can utilize some of the information in their training without having to do the full course. I believe near the end of this presentation, I think we already have a question in the Q&A looking for more information on CRIT. I believe at the end of our presentation, there is and I'll also put it in the chat, there's a link for more information on that. So give me a second and I'll put that in the chat as well.
I think we're ready for the next slide.
So in terms of what different jurisdictions are doing, and everybody will take a bit of a swing in here. You know, we've already talked about CIT and ICAT. A lot of things are happening in terms of really networking and bringing in as part of your network clinicians. And so some really exciting things that are happening now is the ability to do these things through technology, by integrating technology. You know, it's possible for a police officer in many jurisdictions to use a tablet like an iPad or a similar device to actually get a clinician who cannot come out to the scene, but is actually there, just like you're actually with us in this webinar now, and able to talk to a person who's in crisis. There's also technology where officers are able to, in an earpiece or over the radio, get advice from a clinician on how to handle a certain situation, depending on what is going on the scene. There's also a model where mobile crisis teams are not, which are not embedded in the police department, but come to scenes when they're requested or dispatched, and then actually will take over if there's a de-escalation, or if the person winds up going to the hospital. These folks will actually proactively go back, reach out to them, make sure that they are getting services if they need them, connect them with community community embedded groups that can help them with things like, in some cases, you could go to a mental health call and the person is in crisis because their electricity was turned off. And this is the kind of integrated approach that, like, where there would be follow-up on that, and assistance, where a social worker would reach back out to them afterwards and help them maybe get their electric bill situation ironed out. So you have, everything from that to actual clinicians and officers, clinicians that are actually stationed in the police department, going out on calls with officers when requested. And then, things just like with 988 or 911, without maybe without even involving the police, a person can be diverted to a mental health professional or some social services, and whether there's an officer that needs to get involved in that or not. Martin, you want to say anything about this one?
Yeah, I want to just take the opportunity. We're really here talking about implementation here and identifying which approach you feel is going to work best for your jurisdiction and available resources, and then it's really about reaching out to BJA, CSG, CIT International, identifying jurisdictions that have demonstrated some real level of competency in developing and implementing that model, and then doing your best to follow it, work with them, do some site visits if possible. Somebody mentioned earlier that typically speaking, these jurisdictions welcome you with open arms. They're doing good work. They're proud of it. They want to share it. They want others to be successful. And I encourage you to avail yourself of their openness to sharing the wisdom that they've learned along the way.
Randy, if you wouldn't mind, there's a really great question in the Q&A from Sandra Asher, and it's often people with autism and intellectual disabilities are misdiagnosed by crisis responders as being under the influence of drugs and/or mental health crisis. What best practices have been developed to minimize this from occurring? I think this is a great question, and with just the prevalence of folks that are challenged by the spectrum, so to speak, it just is a huge issue in many places. Do you have
I think that's a good point, and do appreciate that question, Sandra. I think that indeed what people become aware is the importance of having that be part of the ongoing training. I know Salt Lake City did a great deal of effort, put a great deal of effort into developing some training in this very area, and then that helped inform Cleveland, Ohio's work with their police department, and they brought in the agency responsible for autism as well as intellectual disabilities, and had them provide a very in-depth training that I know they've shared with others. I would think that hopefully your area has that same training available. If not, I know, as you've heard Sean say, they'll be glad to share it with you, and I would definitely focus with them as well. And that is to contact Salt Lake or be able to contact the Cleveland, Ohio agency that's responsible for that initial training that really worked out quite well. Indeed, a good question, and one that's very, very critical, because I think that, as you point out, there's some very unique elements of responding to people who are struggling with autism. And it's important to be able to have police officers aware of it so that they can hopefully respond in a way that really makes a difference for those individuals and for the community at large. Thank you, Sean.
That is a great question, and I unfortunately I don't have the info to send right now, but we are actually, that is going to be a topic of an upcoming webinar that we'll be having. So that's definitely something that's looking to be more widely educated on. So I will make sure that you get that information when we have that.
Sean, I'll be glad. I mean, Joseph, I'll be glad to send you some of that, those links as well, and you can pass them on.
Thank you so much. And then I think we only have a couple minutes left. So I just want to make sure we get through all the slides. So we have even more great questions in the Q&A. And also, if you're like me and you think of a great question to ask in 10 minutes from now and when we're gone, don't hesitate to send them to my email. I'm happy to make sure you guys get all we need. Is there anything? I actually see we're at the question part of the PowerPoint. So is there any other questions that we think you could hit on in the next 2 minutes that are particularly pertinent, or any kind of closing thoughts?
Holly is asking a question about contacting CIT teams. I would say CIT International has a very good website and is always willing to respond. So I would give them a call as well.
And thank you, Jennifer. I think there is a question here, and this is Martin. I think this is something that we both kind of come across, and certainly Randy, you have too. But from Mark, forgive me if I mispronounce your name, but I think it's Giuliano. And it's really about training of folks. And I think this is it's a legit, it's not really a question, but kind of a comment. I just wanted to point it out to you guys in case one of you wanted to address it.
Yeah, I think that's a really good question there. A good point. I am convinced that there needs to be more specialization within mental health in this field. That is, that I don't think that it is something, it's certainly not something many of us got in mental health, and most of us who are mental health professionals, and one that we do need. And I do think it's important for not only for the work that people do with crisis work, but you talked earlier, Sean, about wellness training, and that is all that mental health professionals that get involved with first responders really do need to understand the culture and the culture differences between different agencies and how they respond. So I do think that that's an area that's really ripe for development. And right now, all I'm hearing from the mobile teams is that they too are having a crisis of being able to find enough people to employ that to be able to handle this challenging work. Not to mention what you saw with the woman who was a social worker who was up on the top of that ladder. I don't know about y'all, but I found that a little dizzying. So indeed a challenge for those that are willing to step up to the profession, indeed.
Right.
And I always, it's kind of like when I did work in the area of sexual assault response and working with victim advocates and so forth, embed them with police. They become colleagues, they're genuine co-workers. They arrive at work together, they go, and they stay there till the end of the day, and they do joint training, and they're always riding along, and they very quickly, that divide quickly comes down.
Yeah.
That's as valuable as any training course.
So if I could, Joe, just real quick, I want to kind of end where I began. Thank you so much, Martin and Randy, for being on this webinar, and thank you, CSG, and thank you, Joe, and all of your staff at CSG for making this happen. Hopefully, the folks that were able to participate got some good information and some things that they can integrate into their community and their agency. And it's been a real pleasure being on with all of you.
Thank you so much. This has been fantastic. like I said before, I do intend to get to all of these questions, including there was one from and I'm sorry if I mispronounce your name, I believe it's Mr. Geyer. We actually have the perfect person to address that question. Our deputy director here at CSG was a San Antonio police officer for 30 years almost, and I believe he started that program and was instrumental in I'm screwing up that word, but integral in forming that policy. So I would love to have him kind of chat with that. So I think that will definitely come up in our follow-up. And if you're unable to make that, I will reach out to you directly to answer that question. So thank you for that. We have the perfect person for that. So just to wrap things up real quick, next slides. I believe, yes. So two resources to take a look at, BJA, and especially I believe Mr. Smoots mentioned earlier about how there are funding opportunities out there, grants. This is a great place to start, to look at that, to see what others have done, to see what's possible, and to see what you can do to join them. And then also, this is the one I also put in the chat. It's a direct link for more information on crits. And then I think the very last slide, if you have any questions, feel free to reach out to me. Like I said, 10 minutes from now, a month from now, whenever, happy to help connect, do anything I can to get knowledge out there. And then don't hesitate to join our distribution list and receive updates on all the other webinars and various events we'll have. So you'll be hearing from me again via email with registration for the follow-up session. Yes, we will be sending out the recording of this, the PowerPoint, and the follow-ups to the questions we weren't able to fit in today. So sorry for keeping you guys over a couple minutes, but thank you all for hanging with us, and have a great day. Thank you so much.
Take care.
Thank you, everyone.
Bye.